Good afternoon. Thank you for joining the IARS Virtual Education Seminar. This is our panel discussion on obstructive sleep apnea in pregnant women. We are going to be giving updates on the screening, treatment, and management based on our recent consensus guideline that is currently under development. This session is being co-sponsored by the Society of Anesthesia and Sleep Medicine. We look forward to talking with all of you today. We have not received any commercial support for this program today. And we will give CME instructions at the end of this webinar. So this is a little plug for the exciting IARS 2022 meeting and this March 18th in Hawaii. And access for the 2021 meeting is still available on demand. And the links for these slides are actually in the chat. There are going to be sort of an ongoing discussion through DocMatter at this URL here. And so we can kind of answer questions and continue to discuss this topic on this platform. And this is co-sponsored, as I mentioned, by the Society for Anesthesia and Sleep Medicine. The group that you're going to hear from today is the Obstetrics Subcommittee of the Society of Anesthesia and Sleep Medicine. We're just part of that group. We've been working in conjunction with many other colleagues in sleep medicine and anesthesiology and obstetrics and gynecology to develop the consensus guidelines that we're going to be discussing with you today. If you're interested in joining our efforts and learning more about the work that SASM does, you can find out more about membership here. And a recording of this webinar will be available to IARS members at this link. And you can submit questions via the Q&A button, and we will be answering them. We will have some time for questions, about 10-15 minutes for questions at the end of this webinar. So I have the distinct pleasure of moderating this session with my colleagues that I've come to know over the last several years through our efforts in the Society for Anesthesia and Sleep Medicine. My name is Jennifer Dominguez, and I am an associate professor of anesthesiology at Duke University School of Medicine in Durham, North Carolina. My interest is in obstructive sleep apnea in pregnancy. I'm an obstetric anesthesiology, and that's the area in which I also do research. After I talk to you about the screening and diagnosis of obstructive sleep apnea in pregnancy, you're going to be hearing from our colleague, Dr. Christine Wan, who is an associate professor of medicine in the section of pulmonary critical care and sleep medicine. She serves as the medical director of Yale's Center for Sleep Medicine and the director of the Yale Women's Sleep Health Program. Her interests include complex sleep disordered breathing and sleep disorders in women. She is also a member of the American Academy of Sleep Medicine's Presidential Committee on Telemedicine and the president-elect of the Society of Anesthesia and Sleep Medicine. Dr. Wan received her medical degree at Albert Einstein College of Medicine and completed her sleep, pulmonary, and critical care training and undergraduate training at Stanford. She's a board certified sleep specialist who's also trained and certified in pulmonary and critical care medicine. After Dr. Wan, you're going to hear from our colleague in Canada, Dr. Mahesh Nagappa, who is an assistant professor and staff anesthesiologist at the Department of Anesthesia and Perioperative Care at the London Health Sciences Centre and St. Joseph's Healthcare in Western University, London, Ontario, Canada. His research interests are on post-operative home monitoring of patients, preoperative virtual visits, digital healthcare, perioperative guidelines for sleep apnea. And he has funding from the Ministry of Health and long-term care for opioid reduction strategies across Southwestern Ontario hospitals. Continuity of care with remote monitoring and cost of home recovery after joint arthroplasty. Dr. Ghada Bourjeily is going to be giving the last section of this webinar today. She's going to be talking to us about research gaps and future directions for this work. Dr. Bourjeily is a pulmonologist and sleep researcher. She's the professor of medicine at the Alpert Medical School at Brown University. She's also the vice chair for research and academic advancement in women's services at Lifespan, and director of research and training at the Women's Medicine Collaborative at Lifespan. She is currently the co-chair of the Society of Anesthesia and Sleep Medicine's Obstetrics Subcommittee. And Dr. Bourjeily's research on sleep-disordered breathing and pregnancy has been funded by NHLBI and NICHD. She has authored over 100 publications and holds editorial positions for multiple journals, and has served in multiple leadership positions at many national and international societies. So I'm very honored to have such a wonderful group of speakers with me today. I'm just going to give you a little bit of background and take you through a little bit of the background that led us to this consensus guideline and this work. So we are today going to quickly review the rationale for which we developed this guideline. Apologize. And then discuss the methods that we use to develop the guideline. Share our progress to date on the guideline, and review best practices for peripartum management of women with sleep disordered breathing. And then, as I mentioned, discuss future research directions. So as a disclaimer, the guidelines presented here are a work in progress. They have not yet been peer reviewed by the SASM Board of Directors or the Society for Obstetric Anesthesia and Perinatology, which is co-sponsoring this work. They do not yet reflect the views of the societies. This is an outline of our talks today. We are going to be first talking about screening and diagnosis, then treatment, peri-delivery management, and then research gaps and future directions. And a little bit of background about how all of us got interested in this work. This graph here is a little bit of the data from one of our colleagues who works with us on this consensus guidelines paper that was published in 2014. Sorry, I don't know why these slides are advancing like that. Go back, bear with me there. So this is the work of our colleague, Dr. Judette Lewis, who published in 2014 a retrospective database analysis of a sample of over 55 million pregnancy-related inpatient hospital discharges, and showed that having a diagnosis code for obstructive sleep apnea during pregnancy was associated with other serious adverse maternal outcomes. After controlling for obesity, Dr. Lewis and her colleagues showed that women who had sleep apnea in pregnancy had 4.5 times increased risk of pulmonary embolism, 2.5 times increased risk of preeclampsia, 5.4 times increased risk of eclampsia, and 9 times increased risk of cardiomyopathy. Soberingly, these women were also 5 times more likely to die in the hospital during their maternity admission. And this work was published by Dr. Bourjeily and her colleagues a few years later. They showed that in another cohort of pregnant women that they demonstrated a number of other adverse outcomes associated with OSA, increasing an increased risk of pulmonary embolism. Sorry, slides are being a little sticky again. There we go. Okay. Dr. Bourjeily and her colleagues showed that women with sleep apnea in pregnancy had an increased risk of pulmonary embolism, cardiomyopathy, congestive heart failure, and ICU admission. So we had these concerns coming from these large retrospective database studies. And then in 2017, the results of a large prospective study looking at over 3,700 women who were nulliparous were released. And in this prospective study, we saw the first prospective evidence that women with obstructive sleep apnea in pregnancy had increased risk for hypertensive disorders of pregnancy and diabetes. And so this slide just gives you a little bit of the sense of the prevalence of sleep apnea in pregnancy. Sorry, my slides are going ahead of me here. Apologize. Okay. All right, so you can see that the prevalence of sleep apnea in pregnancy ranges widely in the prospective study that I just mentioned to you, the FACO 2017 paper, you can see that the prevalence was low. This was a nulliparous cohort of women that was mostly healthy. And in early pregnancy, these women had about a 3% prevalence of obstructive sleep apnea. And in the third trimester, this prevalence went up to 8%. And then there were a number of other papers published in subsequent years of much smaller cohorts, but also much higher risk cohorts, in which we saw reported increased prevalence of OSA in pregnancy in higher risk cohorts, up to 37% in the STREET study. And so with all of this, no clear pregnancy-specific guidelines for the screening and diagnosis of sleep apnea in pregnancy, or the treatment, or the peri-delivery management exist. All of our current clinical practices extrapolated from non-pregnant populations. And so we assembled this group of passionate researchers from the US, Canada, and the UK. And we've been working for the last couple of years on developing these guidelines in these 3 domains. And so we're going to be sharing with you today some of the work that's come out of that. We have had the fortune to have the help of a research librarian that helped us organize a literature search and develop inclusion and exclusion criteria to guide our work. I'm gonna kind of go through this quickly because we do have to get on to our talks here. But essentially we used a software called Providence that allowed us to judge our various papers that resulted from our literature search through a multi-step independent analysis from our team members that yielded 192 studies that we reviewed to develop our guidelines. And we use the ACC/AHA task force statement methods for developing the, or for rating the level of evidence, and then the class of recommendation for each of our guidelines. And we collated data from the individual studies. And where there were sufficient studies, we actually were able to do a meta-analysis for some of our questions. And so the next step is that these guidelines will be reviewed by the boards of directors of our associated societies, and then revised and published. And so again, this is a work in progress. They've not yet been reviewed by SASM or SOAP, and they do not yet reflect the views of our societies. And so with that, I'm going to progress on to the screening section of this talk, which is going to be given by me in a pre-recorded video.
My name is Jennifer Dominguez, and I am an obstetric anesthesiologist at Duke University School of Medicine in Durham, North Carolina. I'd like to thank IIRS for hosting this panel and SASM for its support of our work. I have no financial relationships to disclose. The first set of guidelines I'll present today pertain to the screening and diagnosis of OSA in pregnancy. These guidelines remain a work in progress and have not yet been peer-reviewed by SASM or SOAP, and do not reflect the views of the societies at the time of this presentation. Our first question, and one which is central to the focus of this guideline, is: should all pregnant women be screened for OSA, or just some high-risk pregnant women? Our task force carefully considered this question, taking into account the following factors. Is OSA prevalent in pregnant women? Is there an effective treatment for OSA? And if you screen for and detect OSA in pregnancy, will the treatment be effective at preventing short and long-term adverse outcomes? Regarding the prevalence of OSA in pregnancy, in the largest prospective study of nulliparous pregnant women, we saw that the prevalence of OSA in early pregnancy was 3.8% and increased to 8.3% in later pregnancy. We know that there are effective treatments for OSA, but there is still insufficient evidence that treating OSA during pregnancy mitigates the associated adverse pregnancy outcomes. Taking into account all of these factors, our recommendation is that screening all pregnant women for OSA, regardless of risk factors, is not recommended at this time given the relatively low prevalence of OSA in the general population. However, we also know that in smaller prospective studies that enrolled high-risk cohorts, the reported prevalence was significantly higher. There is evidence that obese pregnant women have higher rates of OSA and that OSA risk increases with increasing BMI. The prevalence of OSA among obese pregnant women has been reported as high as 37%. There is also substantial evidence from well-conducted prospective studies that women with hypertensive disorders of pregnancy and gestational diabetes are also at higher risk of having OSA. While there is still insufficient evidence that treating OSA during pregnancy mitigates the associated adverse pregnancy outcomes, our group proceeded with the premise that knowing a high-risk pregnant woman's OSA status and intervening during pregnancy would provide sufficient benefit to her overall health and peripartum risk for adverse anesthesia-related events that it is reasonable to screen high-risk pregnant women for OSA. In terms of which high-risk women should be screened, we recommended screening obese women, as well as those with hypertensive disorders of pregnancy, including chronic hypertension and diabetes. Both of these recommendations were based on expert opinion. Our task force also considered the optimal timing for OSA screening during pregnancy. Several longitudinal studies have shown an increased prevalence of OSA among women in the second or third trimester of pregnancy compared to the first. While OSA screening later in pregnancy would likely yield a greater number of women being diagnosed with OSA, the logistical and practical challenges of scheduling these women for in-lab sleep testing and treatment during the third trimester are considerable. Our task force also weighed the potential benefit of knowing a woman's OSA status prior to surgery, as there are existing SASM guidelines that recommend OSA management for perioperative patients. For women with high-risk pregnancies in particular, the cesarean delivery rate is markedly higher than that of the general obstetric population, as well as a potential need for early or emergent delivery. These women are more likely to be exposed to the need for intubation perioperatively and to sedating medications that could complicate underlying OSA. Based on all of these factors, the task force recommends OSA screening of high-risk pregnant women in the second trimester between 14 and 26 weeks gestation. This recommendation was based on expert opinion. A number of screening tools have been studied in prospective cohorts of pregnant women with variable degrees of sensitivity and specificity for the detection of sleep apnea in pregnancy. Our group reviewed the evidence for each of these separately. Where there was not a meta-analysis available, we conducted a meta-analysis to help guide our recommendations. The Berlin questionnaire was developed and validated in non-pregnant populations to screen for OSA. It was evaluated in a meta-analysis of OSA screening questionnaires performed during pregnancy that used objective testing to determine OSA status and improved the pretest probability of detecting OSA from 26% to only 38%. So we do not recommend the Berlin questionnaire as a screening tool in this population. The Stop Bang questionnaire was developed and validated in other patient populations as well. Two of the components of the score, male gender and age greater than 50, are not applicable to most obstetric patients. Several small studies of pregnant women evaluated the Stop Bang questionnaire. And given the lack of agreement among these studies, we conducted a meta-analysis of 3 prospective studies that measured the ability of Stop Bang tool to detect OSA in pregnant women and found a pooled sensitivity of 0.58 and a pooled specificity of 0.82 as shown here. Based on the results of our meta-analysis, the task force does not recommend the Stop Bang tool be used as a screening tool in pregnant populations. Flacco and colleagues proposed a pregnancy-specific OSA screening criteria that includes the sum of age, BMI, and points for chronic hypertension and frequent snoring if they are present. In the derived cohort, scores above 75 were associated with OSA in early pregnancy. Subsequently, 3 small prospective studies applied the tool to 3 cohorts of pregnant women, and it did not perform as well as in the original derived cohort. In order to better evaluate the usefulness of the tool, we performed a meta-analysis on the 3 studies and found a pooled sensitivity of 0.78 and specificity of 0.54 and an area under the curve of 0.79. Based on the results of our meta-analysis, our group recommends that the criteria proposed by Facco and colleagues may be a useful predictor of OSA in pregnant women, but further studies in larger cohorts of high-risk women are needed. Lewis and colleagues developed a new OSA in pregnancy prediction model in the large observational new mom-to-be sleep-disordered breathing sub-study that includes maternal age, BMI, and frequent snoring. This is the largest sleep study of pregnant women published to date, and while promising, needs to be validated in another cohort, particularly one with more high-risk women. One limitation of this study was the relatively low prevalence of OSA in this healthy cohort and a lack of high BMI women. Ixi, Balzarak, and colleagues conducted a secondary analysis of a small prospective cohort study that utilized full polysomnography to diagnose sleep apnea in pregnant women at 2 time points in pregnancy. In this cohort, they developed a new model to predict OSA in pregnant women that includes BMI, age, and the presence or absence of tongue enlargement. Scores of 65 or greater in the first trimester were reasonably associated with sleep apnea in pregnant women. This may be a useful screening tool, but also needs to be validated in a separate cohort. Several studies directly compared type 3 and 4 portable home sleep apnea testing to in-lab polysomnography and have shown good agreement between an apnea-hypopnea index derived by type 3 and 4 devices and an apnea-hypopnea index or respiratory disturbance index measured by in-lab polysomnography. Studies show that portable monitoring compared to PSG is generally less sensitive for detecting sleep apnea in pregnant women. This is likely related to multiple factors that I do not have time to review in this talk, but despite the potential pitfalls of home testing, portable monitoring remains an attractive diagnostic modality compared to in-lab PSG due to its relative simplicity and convenience, which may ultimately result in greater capture of women with OSA during pregnancy. And so our group recommends that out-of-center type 3 and 4 home sleep apnea testing may be a reasonable diagnostic tool for OSA in pregnant women. Several prospective cohort studies have demonstrated a progression of OSA during pregnancy, suggesting that OSA risk and severity may be influenced directly by factors related to pregnancy, and therefore warrant reevaluation after pregnancy. Our group recommends that repeat testing may be reasonable. Further research in this area is needed to better understand the evolution of OSA in the postpartum period. There is a paucity of data to guide the timing of repeat sleep testing. Without more data, timing of repeat testing postpartum can only be recommended based on individual or case by case. Thank you so much for your attention today. We'll move on to my colleague, Dr. Christine Wan, who will discuss our recommendations for the treatment of OSA in pregnant women. I look forward to your questions and discussion at the end of this panel presentation.
I'd like to thank Dr. Jennifer Dominguez for inviting me to discuss the section on the SASM recommendations for OSA treatment, diagnosis, screening, and pregnancy. I'll be talking about the treatment section. I have no financial relationships or commercial interests to disclose. So obstructive sleep apnea is a common disorder during pregnancy, and it tends to worsen as the pregnancy progresses. Most of the new onset obstructive sleep apnea tends to be mild, but it has been associated with increased poor adverse maternal and fetal outcomes, including increased occurrence of gestational diabetes and preeclampsia, as well as C-sections and post-op complications. These conditions are also linked to increased risk of cardiovascular disease in women later in life. And although CPAP is the first-line therapy for treatment of obstructive sleep apnea, its efficacy and its impact in pregnant women remains largely unknown. So I'm going to preface this by saying that the questions addressed here by the treatment committee is supported by very little or poor quality data. And this is going to lead to a class 2B or weak strength of recommendations for many of these questions that are addressed. So the conclusion is that the treatment of obstructive sleep apnea with CPAP may be reasonable, it may be considered, and in general, the benefits are thought to outweigh the risk, but its true usefulness and effectiveness is really not well established. This question looked at evidence regarding CPAP effects on blood pressure, hemodynamics, biomarkers of cardiovascular and metabolic disease, or risk of preeclampsia and gestational diabetes. The data are generally limited, consisting mostly of case series with very small numbers of women. In general, however, CPAP did not produce harm in blood pressure or hemodynamics, and in some studies there's suggestion that it might benefit blood pressure. So it was felt that the potential benefits, although not well studied, at least extrapolated from larger population studies in non-pregnant women, that CPAP use has potential benefit and may be considered during pregnancy. So CPAP is shown to effectively reduce apneas and hypopneas and oxygen desaturations. Generally speaking, however, sleep apnea tends to be mild in reproductive age women, and these women are more likely to have RERAs, or respiratory event-related arousals, rather than frank apneas. And there's no data about how CPAP use affects these sleep parameters per se during pregnancy, but it's assumed by very solid data in non-pregnant women that CPAP will effectively treat these sleep disordered breathing events. Now, whether CPAP improves symptoms of sleepiness have been looked at, and while proven to do so in the general population, it has not been clear that it improves sleepiness during pregnancy. And that's likely because there are multiple factors during pregnancy that also affect sleepiness that's unrelated to sleep apnea. And so in the few small studies that have looked at this question, CPAP for the use of reducing sleepiness has not always been shown to be effective. As mentioned, maternal obstructive sleep apnea has been associated with poor fetal and maternal outcomes in large population studies, including the risk of hypertensive disorders and gestational diabetes, as well as post-op complications. However, the evidence for the treatment of obstructive sleep apnea improving these outcomes is very limited, and again, based on very small studies that are not powered or designed to answer this question. Therefore, the usefulness of CPAP for impacting maternal fetal outcomes is really unknown. So obstructive sleep apnea can exist pre-pregnancy, it can newly arise during pregnancy, and it can persist postpartum. And the impact of when OSA occurs on maternal outcomes is really unknown, but potentially different given the difference in exposures. There's also very little data to know when the optimal timing of treating OSA during pregnancy is. And so with these lack of evidence, it was recommended by the committee that pregnant women with OSA be treated similarly to non-pregnant women with OSA. So adherence to CPAP in reproductive age women is generally lower than the larger population. The reported adherence rates during pregnancy vary quite a bit from study to study, from 40% to as much as 80+%. It really varied according to the definition of adherence, as well as at which trimester adherence was being measured. But what is known is that some women are reliably able to use CPAP regularly. Now, there are likely very unique barriers to CPAP adherence during pregnancy. For example, chronic nasal congestion that pregnant women suffer. Pregnant women may also be more prone to reflux, as well as positional limitations. And how these affect CPAP use in pregnant women has not been well studied. Finally, these were questions that the treatment group addressed that really had no data to confidently support a recommendation. In general, the consensus by the group was that there was potential, though not proven, benefits that outweigh any risk of CPAP use during pregnancy that has been shown. However, whether CPAP use will in fact impact preterm birth, gestational duration, or NICU admissions and other outcomes, there was potential, though not proven, benefits that outweigh any risk of CPAP use during pregnancy that has been shown. However, whether CPAP use will in fact impact preterm birth, gestational duration, or NICU admissions and other outcomes have not been shown. So with that, I'd like to thank the Society of Anesthesia and Sleep Medicine for addressing these very important questions, and the International Anesthesia Research Society for allowing us to highlight the areas where more data is needed to improve these recommendations for pregnant women with obstructive sleep apnea. Thank you.
Good afternoon, everyone. Hope it has been a good day. My name is Mahesh Nagappa, Assistant Professor from Western University. Today, I'm going to discuss the peripartum considerations for the management of patients with obstructive sleep apnea. I have no financial disclosures related to this presentation. A 34-year-old pregnant woman at 28 weeks of gestation. She was diagnosed with preeclampsia and hypertension. She recently had a PSG and found to have obstructive sleep apnea. She was treated with CPAP. CPAP helped her to prolong her gestation, and she delivered without any adverse maternal or fetal outcomes. However, she was found drowsy, sedated, and in type 2 respiratory failure within 12 hours after delivery. She was intubated, stayed in the ICU overnight, and then extubated uneventfully. Later, she was discharged home for a follow-up with a sleep physician. This is a typical example how an OSA patient can have prolonged length of hospital stay, higher risk of ICU admission, and increased cost on the healthcare system. Once the patient is diagnosed with OSA, it is good to have an early anesthesia consultation, which will help to understand the patient need and the expectations in the peripartum period. To prevent the maternal and the fetal adverse outcome related to OSA, it is important to have these consultations in the second or the early third trimester of pregnancy. Because the OSA is very dynamic in nature during pregnancy, it is good to have a multidisciplinary approach and request the sleep physician in the care team for the continuity of care. During these consultations, it is important to create an expectation and inform the patient regarding the benefits of using the CPAP throughout the peripartum period. Patient needs to use the CPAP every day for at least 4 hours during the sleep and bring the CPAP to the hospital for the continued usage. Some institutions may even have the policy to recognize these patients with an alert band. The most common finding identified in these patients is desaturation. Desaturation is a very big umbrella term because different authors use different definition for desaturation. Any desaturation of more than 3 to 5% of the baseline value or an absolute desaturation value of less than 90% should be investigated for acute disease process. Hypoxia in OSA patients may have some unique characteristics. It can be intermittent, may be associated with drowsiness, or may have positional variation. When I say acute disease process, some of the differential diagnoses for hypoxia to be considered are pulmonary edema, all three types of emboli, any respiratory tract infection, of course, the exacerbation. The three important considerations during the management are the timing and the choice of the anesthetic, the difficult airway management, and monitoring. How to monitor these patients. OSA patients are extremely sensitive to respiratory depressant effects of anesthetic medications like sedatives, opioids, and inhalational agent. To prevent the respiratory depression, an early placement of neuroaxial blockade is very important. We do that routinely for all OB patients, but it becomes even more important in this population to keep the failure rates very close to 0%. We need to consider the patient factors, the comfort level of the anesthesia team with the anesthesia technique, and the institution protocols when we execute one of the following options to our patients. We all know that in combined spinal epidural, we deposit the medication directly into the subarachnoid space. Whereas in the dural puncture epidural technique, we transfer the medication from the epidural to the subarachnoid space. Each of these techniques has a faster onset of analgesia, lower risk of epidural failure rates, at least in the experienced hand. Regarding the neuroaxial adjuvants, even a small dose of neuroaxial opioids like morphine may greatly benefit these patients by decreasing the systemic opioid requirement. Some institutions may use the non-opioid adjuvants like clonidine. However, the evidence is still building in this aspect. Some of the acceptable alternatives to central neuroaxial blockades are ultra-short acting and the short-acting opioids like remifentanil and fentanyl respectively. We cannot change what we cannot monitor. As we discussed, desaturation is a very common finding in these patients, so monitoring for hemoglobin oxygen saturation with a pulse oximetry is highly encouraged. The monitoring should happen during labor and at least 12 to 24 hours after the delivery. As we mentioned in this case, patient became very drowsy and sedated. I would say drowsiness in these patients may be a pre-respiratory arrest stage. Monitoring for CO2 would be very helpful in such clinical conditions. Some patients may need the transient ventilatory support, either invasive or non-invasive methods. Depending on the patient's clinical condition and the facilities available at the institution, such patients can be monitored either in the ICU, step-down unit, telemetry bed, or in any room by a trained professional. Of course, general anesthesia is not the first choice of anesthetic in these patients. However, it cannot always be avoided. Most of the litigation cases on OSAs are on failure to re-intubate after extubation or failure to re-intubate in the recovery room. So emergence from general anesthesia is very important in these patients. Pre-oxygenation is a very important step. We need to make sure end-tidal O2 is as high as possible before inducing these patients. These patients are also at high risk of rapid desaturation. Once desaturation happens, an easy intubation can become a difficult intubation. You can use the simple methods like this, nasal oxygenation, to prolong the no desaturation time. There is no excuse to intubate a difficult airway OSA patient in a bad position. Appropriate positioning is very important in these patients. Video laryngoscope has a very high success rate in these patients. These patients are at higher risk for residual neuromuscular blockade and associated complications. Evidence from obese OSA patients in the non-OB population show that Sugammadex can reverse the neuromuscular blockade more rapidly with fewer adverse events than neostigmine. Supplemental oxygen with patient in upright position in the recovery room would help the patient to ease the work of breathing. It would also increase the tracheal diameter by at least 1 centimeter. If any one of these events occur in the recovery room, then we continue to monitor these patients. We usually monitor in 4 blocks of 30 minutes period each. If no events occur, then the patients will be good to transfer from the recovery room. For pain relief, if we are restricting the opioid medications, then we need to provide more options with the non-opioid medications. The best is always the multimodal approach. Even a small dose of neuroaxial morphine is very effective for the pain control. Even though the regional techniques and the blocks are not as effective as neuroaxial opioids, but they decrease the systemic opioid consumption to a great extent. CPAP should be continued after delivery. Of course, the weight loss and decreased oropharyngeal edema may help to relieve the OSA symptoms and improve the quality of life. The continuity of the care for CPAP titration with a sleep physician is very important for the old. Most of the literature is on screening and the maternal and the fetal outcomes. The evidence is still increasing on the other parts of the management. I would like to thank SASM and IARS for this wonderful opportunity. Thanks to the SASM OB group for the excellent team collaboration. Finally, I would like to thank you all for your valuable time and the kind attention.
Hello, my name is Ghada Bourjeily, and I would like to thank the International Anesthesia Research Society for inviting us to speak today. My role on the symposium is to speak about summary of the findings we discussed, the gaps in the literature, and what future directions we would like to take these data. So I have no conflict of interest to disclose. So as you heard today, in terms of screening for sleep apnea, it is reasonable to screen women that have an elevated BMI, women that have hypertension or diabetes mellitus, and it is likely reasonable to screen women in the second trimester. Having said that, it's important to understand what the limitations of this are and to expect these recommendations to change as more data becomes available. The reason for the second trimester is that the prevalence is likely higher for sleep disorder breathing as pregnancy progresses. In the second trimester, you still also have time to perform an intervention if you need it. So if you need to start someone on therapy, you still have enough of a window in pregnancy to do that. But there are some caveats to that information, and we'll go over that in a second. So these are some unpublished data that we have from high-risk women that had an elevated BMI of 27 or more and had habitual snoring. So they snored loudly 3 to 4 times a week or more. And what we found was that in early pregnancy, so around 14 weeks or so, pregnant women had sleep apnea in about 20% of the cases that we screened. However, when we took the women that did not have sleep apnea in early pregnancy, but had the same characteristics in terms of the risk, and we repeated their studies in late pregnancy, so at an average gestational age of 32 weeks of gestation, now 40% of all these women that did not have sleep disorder breathing early in pregnancy now had obstructive sleep apnea, and that was defined by an apnea-hypopnea index early on. So that highlights that there is a good chunk of women that we don't identify early in pregnancy that we may still identify later in pregnancy that have the issue. And to illustrate this point even further, we published a report earlier this year about a woman who in the first trimester, she had a Berlin of 3, stop bang of 3, she had a BMI of 31, and a Malampati grade of 3, but only had an apnea and hypopnea index of 3.3 events per hour, as you could see in here. When we studied her again in later pregnancy, her BMI had gone up, but she was abnormal to start with. Her stop bang also went up and Epworth went up. But the most interesting thing was that her apnea and hypopnea index was now 69 events per hour. So she went from 3.3 to 69 events, putting her in a very severe category. So this is what her sleep apnea monitoring test looked like in early pregnancy. She had some airflow limitations that you could see in here, but she did not have events or enough events that met criteria for apneas or hypopneas. When we studied her in the 3rd trimester, you could see all these apneic events that she was having that explained the higher number. In addition to that, we looked at the women we had screened in early pregnancy, and we measured their C-peptide and glucose, both fasting, and calculated the homeostatic model assessment for insulin resistance in early pregnancy. And what we found was that when we looked at the associations of the respiratory event index, which is another word for apnea hypopnea index, and looked at that association with HOMA insulin resistance, we found that there was a significant association even after we adjusted for multiple covariates, including age, race, ethnicity, etc. We did the same thing with the oxygen desaturation index and looked at that association with insulin resistance and still found significant associations between the two. So what these data show is that, one, some women may not be identified early in pregnancy or maybe early 2nd trimester in pregnancy, and they may only be identified later in pregnancy. But for the women that we do identify in early pregnancy, there is a significant association with insulin resistance, which is a precursor for gestational diabetes. So that tells us that we may need to screen in early pregnancy regardless, because if we do need to intervene and prevent gestational diabetes, for instance, by treating sleep disordered breathing, we may need to do it early on when we identify these precursors and before the actual clinical manifestation happens. And there are also some trials that are ongoing that are looking at the association of treatment of sleep disordered breathing with preventing hypertensive disorders of pregnancy. And if these identify that treatment is going to reduce the risk for developing preeclampsia, for instance, we may need to screen for the disorder sooner rather than later so that we have time to modify biology and modify the clinical manifestations. We also discussed in screening that the tools to use for screening for sleep apnea are not appropriately validated. Some of them just don't perform well, period. Some are promising, but they have not been validated, especially in high-risk populations. And we'll talk about the gaps in the literature later and what we need to do about that. Now, we also talked about labor and delivery, and as you heard from Dr. Nagappa, we had many more questions than we had answers, and actually we barely found any answers. So the way we decided to approach this is by doing a consensus review using the Delphi methodology with a group of the subcommittee to try to identify these questions. When it comes to treatment, we decided that usefulness was unknown for treatment of sleep disordered breathing in preventing maternal outcomes, such as hypertensive disorders of pregnancy or gestational diabetes. The usefulness was also unknown in preventing fetal and neonatal outcomes. However, it is likely reasonable that for women that are symptomatic or have a poor quality of life, that treating their sleep disordered breathing and their obstructive sleep apnea may actually positively impact these outcomes and help these women. Another issue that we need to consider is that since CPAP is the gold standard treatment for sleep apnea in pregnancy, what do we need to know about pregnant women in order to encourage them to be more CPAP adherent? There are multiple issues that may be either pregnancy specific or non-pregnancy specific, that might impact CPAP adherence. And there are some factors that may also facilitate adherence to CPAP. And some of the facilitators might be a partner's influence, concern about the fetus. Some of the barriers could be provider messaging, where some of the providers for pregnancy care may not know about sleep apnea in detail, and there may be some discrepancies in the messages that the women are receiving. Some of the examples that we're getting in a qualitative study that we're currently performing on facilitators and barriers of CPAP treatment go something like this. So we have a group of women that are pregnant and another group of reproductive age women that are not pregnant. And the first example is from a participant who's not pregnant. And she says, I have a 20-month-old who's full of energy, and I don't want him to have to get a 40 or 60% version of his mom, you know? And then a pregnant person said, being pregnant, you feel like you have that extra responsibility, right? To be more compliant. So some of these things are things that we don't necessarily discuss in the care of these women, and identifying themes of what might be some important facilitators can help us in addressing these issues better. So where do we go in terms of future research? When we think about screening and a good screening test or an ideal screening test, it would be something that would have a low false positive and a low false negative rate, high sensitivity, high specificity. And we are not there yet. So we need to identify these tests and we need to validate them. But we also might have to consider either combining questionnaires with anthropometric data or physiologic data, or identifying some separately. And we may need to do that at different time points in pregnancy because of the dynamic nature of the physiology of pregnancy changing with time. Now, how about diagnosis? Are we okay using level 3 devices or level 2 devices, for instance, in diagnosing sleep disorder breathing in pregnancy, or should women be tested in the lab? There are many questions. I would need to say that level 3 devices have been validated in the course of pregnancy. Sorry about that. But there are many other questions. So there are questions that remain about the usefulness of the apnea-hypopnea index, and not just in the pregnant population, but in general. Do we need to look at other measures that may be more predictive of outcomes, for instance? Should we look at airflow limitation even outside of hypopneas and apneas? Or do we need to look at alternative measures? Recently, we published a paper on looking at pulse transit time, which is a measure of intermittent arterial stiffness that may be related to upper airway obstruction, and found that there were many more pulse transit time drops, which suggest an increase in arterial stiffness than there were apnea and hypopnea events, which suggests that there is biology that is happening that we may not be capturing by our very conventional criteria of apneas and hypopneas. In terms of labor and delivery management, as I said, the territory is wide open for research. There are many questions that remain to be answered, including questions about monitoring, about the choice of analgesics and anesthetics and magnesium and fluid management and early epidural. So there's a lot that we need to do. In terms of treatment, we also need to look at the impact of therapy on cardiovascular and metabolic outcomes in pregnancy, also on fetal and neonatal outcomes, but also on long-term maternal and neonatal outcomes. So does it make a difference to treat these women during pregnancy and after pregnancy? And does that impact how well the mom is and the intrauterine environment of the fetus that may impact the child's or the offspring's health going forward? And then how do we counsel these women in a way that is specific to the pregnancy and that would help ensure their adherence to therapy? Are things that we still do not know and need to find answers about. So to complete this, I want to thank everyone. I would like to thank the whole team. Yes, there were 4 of us that were presenting today, but this was work of a much bigger team, and we could not have done it with everyone's help. Thanks again for the invitation.
Thanks everyone for your attention today. See, we have a couple of questions here in the chat. I'll direct this question to Dr. Bourjeily. One of our attendees has asked, can the risk of hypertension and diabetes reported with OSA in pregnancy be related to the morbid obesity itself?
This is a really important question, and one that many researchers have tried to answer. And from what we see, but understanding the limitations of the methodology that is being used, that the association seems to be independent from BMI. So there have been multiple studies that have looked at it, and whether it's the prospective data or the population-based or national registry data that have adjusted for obesity, but the prospective data had adjusted for BMI. And it looks like the association is definitely independent from BMI. So yes, obesity is associated with these risk factors, but it is likely that obstructive sleep apnea adds to that risk on top of the risk of obesity.
Thank you, Dr. Bourjeily. We have another question here in the chat. What anesthesia was given to the patient who developed the type 2 respiratory failure? I think that's a question for Dr. Nagappa.
Thank you so much. It was epidural, and then patient had a C-section, and then the patient went to the recovery room. And later it was realized that the patient had received some antihistamine. So this was just a scenario to say that even a very little small mistake in these patients, they can end up in type 2 respiratory failure.
Yeah, I think that's a good point to bring up, that it's not just opioids that these patients can be very sensitive to, but the careful use of any sedating medications, including sedating antiemetics, can be problematic in patients with sleep apnea. On the labor and delivery unit, we use a lot of antiemetics, and so that's one area in which patients can get into trouble, especially during the postpartum period in our clinical experience. Any other questions in the Q&A? Okay. So I actually had a question for our 2 sleep medicine specialists. Dr. Wan, I can direct this to you first, but I wondered if you could talk to us a little bit about the way in which patients get referred to you, obstetric patients, so during pregnancy, and sort of what the pathway is at your institution and how early you're seeing these
Sure, thank you, Jennifer. I think it's, you know, with pregnant women, as you mentioned, it's sort of a time-sensitive referral. So for our specific institution, just because, you know, I'm involved in sort of breathing women, we've actually devised a pathway. It's 5 o'clock. For our pregnant women to be expedited through our clinics, and then our sleep testing, and we do home sleep testing again, mostly for the convenience and just the availability and the expedited diagnosis. Treatment is always obviously a barrier, because anyone who practices sleep medicine out there knows that, you know, there is a delay between getting diagnosed and insurance authorization for treatment. So that could take on the order of, you know, a couple of weeks to, you know, 6 weeks for CMS patients. So that is definitely a barrier, and sometimes, as was mentioned, you know, right now the data seems to indicate that maybe second trimester is the highest yield in capturing these at-risk women for sleep disordered breathing. But that does give us very much a time constraint in terms of getting them treated and diagnosed. And then you're going to have women who are on treatment only for a couple of weeks. And does that even impact outcomes? We really don't know. The feeling is that, the longer exposure to treatment, hopefully the better outcomes. So we really do have to work on sort of an expedited treatment for the pregnancy population. Unfortunately, we don't have that now. We're just kind of doing what we can do. But I think with these guidelines, if you can show that treatment impacts outcomes, that maybe the insurance barriers would be more generous.
Thank you so much. Let's see, we have a question in the chat about neonatal outcomes. So one of our panel, someone watching our presentation is asking if OSA is associated with fetal death in some cases. So Dr. Bourjeily, I'll let you answer that, if you don't mind.
Yeah, this is an interesting question. There's not much in the literature about OSA and fetal death. We looked at it in a prospective cohort. We wanted to see if the rate of miscarriages or stillbirth was elevated, but it's a prospective cohort. Fetal death is a really rare outcome. So in order to identify that, you need to have larger data. We also looked at it in a population-based sample. We had a little over like 1.5 million mom and baby linked records, but we did not find a significant association there. Now, there are some data that are coming out about sleep position and stillbirth, but the data is mostly case control, and it's asking the women after the occurrence of a stillbirth or their controls whether they had slept in a supine position the week prior to the stillbirth. And the data looks like there is an association, but sadly, I have to say this again, it is post occurrence of the outcome, and the data might be biased in that way. But the idea is that in the supine position, there's a higher potential for upper airway obstruction, as you all know. So if that association is there, part of the explanation for the association is that there may be upper airway obstruction related to it, but there's also a whole other pathway that might explain it, and that would be that in the supine position, there's compression of the inferior vena cava, which might impact venous return to the heart and impact placental perfusion and lead to that. So the short answer is not enough data to suggest a direct relationship between sleep apnea and stillbirth or even miscarriages to this point, but I think that's something that does need to be addressed in the future, definitely.
Thank you. Let's see, there's another question in the chat about postpartum monitoring. So Dr. Alian asks, what are your thoughts on different monitors for OSA about end-tidal CO2 monitoring versus Expiron monitor, which is the chest wall monitor that monitors chest wall excursion and hypoventilation events. Dr. Nagappa, do you want to take that one?
Yeah, sure. Yeah, thanks for that very good question. Like if you see the legal litigation cases on the OSA, most of the adverse events have happened with intermittent monitoring, especially 30 minutes after the nurse has checked into the room and they have left the room, and then found with the next checking, the patient was not breathing. So definitely continuous monitoring clinical side will be very helpful. But we don't have enough data in the literature to clearly suggest continuous monitoring will help for all patients because we still do not know whether it's the severity of the OSA or whether a specific type of phenotypic OSA who is susceptible for these type of adverse events. We have no answer at this stage. But definitely to keep our patients very safe, continuous monitoring would be very helpful. Once again, the cost factor will come into effect.
Well, I think we're at 5 minutes after the hour and our questions have tapered off here in the Q&A, so we'll conclude. But Just want to thank our co-panelists today, Dr. Bourjeily, Dr. Nagappa, Dr. Wan. I want to thank IRAS for inviting us and SASM for co-sponsoring this event. And we encourage you to continue this dialogue in the Doc Matters platform, and also to claim your CME. Thank you so much for attending. We appreciate your interest in this topic, and stay tuned for our guidelines, which we hope to see published in 2022. Thanks, everyone.